I'm. Thank you for asking me to come, and I don't expect to have all the answers, or you have a lot of wisdom and knowledge, so I think it will be a two-way street. As far as giving presentations, I try to minimize the use of PowerPoint. Can you hear me okay?
Yes.
Yes.
Yep. Because I always find when I go to conferences, it's distracting. I can't concentrate on the PowerPoint and the speaker. And most of the stuff on the PowerPoint could have been emailed ahead of time. So that's my philosophy as far as presentations. And I do believe in interaction. So I may throw out some questions. I do have one page just to show you what I'm going to address, if possible. So I'm going to just, if I can share the screen. Yeah, okay. Can you allow me to share?
Yes, please.
No.
I'm making you the host,
Okay.
and I can't make you a co-host. I don't have this possibility. So
Okay.
then you can share.
Yeah, it's not letting me share.
Try
Okay.
now.
Okay, now there's a sign there. Okay.
Then, Jonathan?
Yeah, it's working. Um, okay, so this is just what I hope to cover, but that may change depending on the interaction. I'm going to talk about the opening, the first interview, the first question. Common processes and languages in the experiential dynamic therapies and STPPs, which I believe are the same, and some of the core processes, engagement defenses, core emotions and relational themes, choice points and action alternatives. And I have a video, a short video, if we have time, we'll look at during the talk. Okay, so I'm going to stop the sharing. So I'm going to ask you, each of you, if you take a couple of minutes, when you see a new patient who's been referred or presented for your first assessment interview, I want you to think, what is, if you have a specific question that's your first question. So I want you to think about what's your first question, or what's the first thing you say. So we'll start if anybody wants to jump in with that. I can just go in the way the screen is. Joop, what's your first question?
My first question is, what brings you here today? Very often, not always, but very often, what brings you here today? Especially if I do know very little about the patient. Sometimes I have a lot of more information, so then it might change. But if I have less information, it will be somewhere along the lines of what brings you here today.
Okay, thank you. And then Jönan Weisman.
I usually ask, what is the problem you would like my help with?
Okay. And Yair.
I also asked patient what are the problem that you want my help with.
And Jonathan.
I normally begin with what brings you to therapy, and then what is the problem if the answer doesn't apply.
Okay, thank you. And Galit.
Galit, you have to unmute.
I asked, how are you today? And yes, what brought you to me?
And Yoram. Unmute. Still on.
Jonathan, בהשתק.
It's not unmuting.
You can speak.
I'll come back. Ran, what's your question?
Are you comfortable here sitting? Do you need to feel comfortable? The temperature of the room and the way you want to sit now.
Okay. And Julia?
Yeah, sometimes probably how can I be helpful? And sometimes what kind of theme do you want to dedicate our therapy to?
Okay. Anybody else? Yoram, is your unmuting working? No, it's not working. Okay. And Ehud, what's your first question?
I guess usually I would ask, what is the problem? You need help from me, or something like that.
Okay, so I will show you a little video later. It's a simulation, but it's quite realistic because I did it with one of my psychiatry residents who is also trained as an actress. And the way we made the video, there was no scripting, there was no rehearsal. It was one shot, 20 minutes, because the way I make them is I get the actor, the patient, to think of a patient of their own and then to respond more or less as that patient would, although they can change it and mix things up. So me, as the interviewer in the simulation, don't know what's coming. So it's much more realistic, and sometimes I have to really work to respond to what they're throwing at me. So I'm going to show you that later. But my first question, which I started using a few years ago, I'll have to admit them, I guess, is how do you feel, once they get inside the door, walk down from the waiting room, once we sit down and say, how do you feel about coming here to see me today? Because any idea why that's an interesting question?
It brings the relationship.
Yes, bingo.
That's the beginning.
You get right into the relational dynamics. Now, not everybody can handle it, depending on, but some people are not psychologically minded. But those that are, it's a surprise. I call it the surprising or unexpected question, because if you've gone to a therapist or a doctor, they don't usually ask you that. They ask, what's your name, where do you live, what's your problem? And each specialty has a slightly different opening question. The family doctors here will say, how can I help you today? Well, when I go to my family doctor, it's not just today. I've had this problem for a long time, and I want more than just focusing on today. So the opening question sets the tenor. And if you do the surprising question, it's also a corrective experience, a corrective emotional experience, because I didn't expect that. It's disconfirming. If somebody comes in and they're used to be pushed around or rejected or not listened to, this is quite a dynamic, forceful interaction. And then whatever comes up, well, I was frightened, or I didn't want to come because somebody made me come, or I thought I'd be judged. You're into all the person's view of themselves right from the get-go. And as I say, not everybody is able to handle that. If they can't handle it, you just, you back off and you go into more concrete stuff. But for the ones that can, it's very powerful. Now, I'm mostly influenced, I suppose, by AEDP. I trained originally in my psychiatry residence when it was interpretive. The focus was on interpretation and, Freudian concepts. And it wasn't we know now that interpretation is not very powerful. With the experiential therapies, the money is on affect, emotion. And I think that's one of the common elements, of course, getting past defenses to core affect. Somebody said, not dreams, but affect or emotion is the royal road to the unconscious. In ISTDP, they call it unlocking the unconscious. In AEDP, Diana Fosher calls it getting to core affect or core state. One of my goals is to try and look at the common elements in those, in certainly the three main forms of short-term that I was familiar with. Diana Fosha, Davin Low, and Alan Abbas, who's the main guy now, and Lee McCullough, and then Kristen Osborne. And my view is that the language is different to some degree, but the basic processes are exactly the same. The basic process is establish a relationship, engage, get past defenses to deep affect, focus on the affect, stay with the affect, and allow the person to re-experience the affect in a different environment from when they experienced it in the past. So somebody who was traumatized or abused, so when they experience the affect, it's toxic and destructive. If they're able to gradually with time experience the affect in the presence of a therapist who they feel safe with, in the language of attachment to which they have a secure base, that is therapeutic. Not only that, you're going to reframe or reinterpret the narrative about those memories. And the memories then are restored back in the amygdala and the hippocampus and the brain, but they're changed with a different valence. The emotional intensity is weakened. So that's called the memory reconsolidation theory of how psychotherapy works. You take out the memories, you change all the emotional stuff because of the nature of your relationship and your responses, being empathic, validating. And then the memories get stored, but without the intensity of the emotions. I think all the treatments for PTSD work on that model, including EMDR and the less mainstream ones, basically re-experiencing in a moderated degree some of the feelings and memories, and having those memories changed, where the individual may blame themselves for being abused. Now they're learning that it actually wasn't their fault, and they're able to talk about all those things with somebody who's empathic and respectful and understanding and so on. So those are core, I think, to all the EDTs. You can correct me if you think I'm wrong. And feel free to challenge me as we go along. You don't have to wait. So core processes and then language. So psychodynamic language is very difficult. We used to teach, we only had 8 or 10 sessions with the psychiatry residents to teach them psychodynamic. So we taught them about Freud and Winnicott and Melanie Klein and Fairbairn and that's very interesting and fascinating and very enriching. But unless you're going to be really doing psychotherapy full time, you don't actually need to know a lot of that. The example I give is to learn English literature, to study English literature at university. You don't have to learn Latin and Greek, although that used to be the case when I was younger. Most of you won't have any experience of that, but Latin and Greek, because so many words particularly come from Latin, and we all learned Latin in high school. It's interesting and it gives a certain finesse, but it's not critical. So my view is that you can read that stuff, but basically when you're starting off, you need to understand the basic processes. And to me, the two fundamental sciences for psychodynamic therapies are attachment theory and affective neuroscience, not so much cognitive neuroscience, affective neuroscience as described by Jack Panksepp. So I'm going to pause for a few minutes just to see if there's any questions on what I've said so far. Anybody disagree or have alternative opinions or not understand what I'm saying?
Hi, I would just add, I think, that Jaak Panksepp's work is in a way an extension of drive theory or an updating of drive theory. Because that's the roots of psychoanalysis, right? So, and modern psychoanalysis and modern dynamic psychotherapy is rooted in attachment theory, but we've come to sort of abandon many of the ideas of drive theory, or seemingly, not so much in AEDP and ISTDP and EDT, because that's still really baked in, I think, in these approaches. And so I think it's good to link it back. So core affect, I believe is linked to drive theory. It's just an updating of it. It's not just thanatos and libido, two drives. We have at least 7 core drives, which is a huge update.
Yes. So, yeah, that's, I think what you're saying is true. To me, attachment theory evolved, as you probably all know, from object relations theory, and largely in the Tavistock Clinic in London. So after and during the Second World War, many analysts, mostly Jewish analysts, ended up in London or North America. So the ones in London came from Austria, Germany, Hungary. And from what I can make out, I think the Hungarian group who descended from Ferenczi really were the ones that moved into the object relation. So you had the Ballant, Michael Ballant and his wife, who David Mallon learned from. There was a couple of other ones which I referred to in the book, but they moved to a more interpersonal model. There was the object relations, Melanie Klein on the one side, but Bowlby, of course, was analyzed by Melanie Klein and I think Fairbairn. Winnicott was, I think it was Winnicott. Winnicott, I still see as really the main precursor to attachment theory. And they were all together in this Tavistock clinic in London. And Winnicott used different language. And he talked about the capacity to be alone, good enough mothering, which are directly similar to Bowlby's concepts. But Bowlby wanted to make them more scientific, get rid of some of the early language that wasn't empirical, and actually study children and look at how they behaved. And so attachment theory is definitely derived from those concepts. And affective neuroscience is biologically based in what I still call the limbic system, which is the neuroanatomy. There's three parts of the brain. There's the neocortex, the higher cortex, there's the limbic system, and then there's the reptilian brain. That's a very shorthand, but it's a very useful way of just shorthand thinking about it. And the big debate we have with the cognitive therapists is that they believe that the cortex is stronger than the limbic system. And I said they only have to look at Clinton's life history to realize that was wrong, because he knew what he did was wrong, but he still did it. And that's because the limbic system is stronger than the cortical system. So I work here in a clinic. Most people are psychologists who do cognitive therapy. I'm an imposter, but they don't mind because they send me the difficult patients. But anyway, but I really believe that our core emotions like anger, love, fear, even disgust is listed, joy, those are core visceral emotions that you will see in animals. And of course, Panksepp did his research on animals and didn't get funded for many years because of that by the mainstream. But I mean, it doesn't take much to look at ourselves, and we know we have these feelings. We know how strong they are. And we can even see them in some animals, indicating that these are core biological processes. But we're not limiting them to the language and the associated theories that Freud had. Well, we're not, but some of the analysts might be. But we're looking at them as biological processes. Now, the interaction between the cognitive level and the visceral emotional level, there is a complicated interaction. What is an emotion, what is a feeling, and what is an affect? And I don't have the answers because different theorists use different concepts about what types of emotions there are. But it may be that there is this constant interaction between the affective level and the thinking level. It's the way I see dynamic therapy is getting to the core affects, and Diana Fosha has a list of categorical core affects. Not all the writers have the same, but there's common ones, and I mentioned them, I think. And Panksepp lists them as systems. Sex is another one, or the seeking system, looking for things, exploring. So core affect and the cognitive level do interact, because when we evolved, we had a reptilian brain, then we had a mammalian brain, and then we had a cortex. The problem was we never got rid of the first two. And all we did in evolution was we added another layer on top. So even though we have this cortex, it can't really control the other levels. There are ways you try to control it, but it's difficult. So I think affect is where it's at. That's why I like dynamic therapies, because it seems you can feel it, you can see it. And it's interesting to work surrounded by cognitive therapists, and the contrast from the way we approach things is very interesting. Now, there is a convergence. Cognitive therapy is kind of imperialistic. It's acquiring more and more ideas from different therapies and claiming that it's part of CBT. So we have different names for the same thing. So we talk about the unconscious, they might talk about implicit memories. We talk about portrayals and imagery. They talk about imagery rescripting. And as far as I can see, they're very similar concepts. So that's what I see as the core process in dynamic therapies. Now, the differences between the three groups, I don't know, I'm not an expert on Farooqi. Well, I've just very little familiarity, and that's why I wanted to attend to the other meeting with Farooqi, because I wasn't familiar, other than reading a little, about his methods. But I think it's pretty well overlaps, particularly with ADP and ISTDP. It's a little bit. One of the main differences between Davin Liu's ISTDP and Diana Fascia is the way they deal with defenses. Now, it's interesting that Davin Liu produced a lot of people. So Alan Eppel trained with Davin Liu, Diana Fascia trained with Davin Liu, Farooqi trained with Davin Liu. There's a couple more. And all of those people went out and they changed a little bit. The big change that I'm familiar with is Diana Fascia did not like Davin Liu's approach. And somebody said that his style is patriarchal as a male, and Diana Fascia's style is matriarchal and female, meaning that Davin Liu appeared to be come on very strong, to be confronting, although people say it's not really confronting, it's also being empathic by paying so much attention. So Diana Fascia did not like that applied to patients, or to herself, I guess. And her approach was get past defenses by empathy, by bypassing them, what she calls by melting them. Melting them with empathy and some disclosure, about the impact of the patient on them. But the basic process is, and the same in Lee McCullough's affect phobia therapy, is getting past the defenses so you can get to the feelings. So to me, as far as I can see, that's common even in psychoanalysis, although it appears to be slower in psychoanalysis because the analysts may not talk and they sit behind the patient, right? Which has all got to do with Freud's own preferences. But anyway, now affect phobia therapy also conceptualizes it a little bit differently, because Lee McCullough worked with behavior therapists at first. So she still uses defenses and all the same language, but she sees the main therapeutic factor as bringing up the emotions and desensitizing people to emotions. So she can see it in behavioral terms. So she was able to blend the two. But again, basically it's the same model. So when I talk about common processes, that's what I mean. Common language. There's so much confusing language when students are reading. If you want to get into the original psychodynamic literature, I mean, it is very rich, but sometimes it gets to the point where it's so abstract that you kind of depersonalize or dissociate because it's not even, I've read papers and I've gone through them and I just can't even figure out what it means in simple terms. Certainly our students didn't like that. So, and some of the language is very archaic, you know, Melanie Klein with the good breast and the bad breast, and they're interesting and they're metaphorically maybe stimulating, but it's very hard for younger generations to incorporate that unless they have a special interest. So I tried to translate as many of these terms into neuroscience or attachment language so that therapeutic alliance can be called a secure base. Attachment style is often parallel to defenses. There's still a lot of specific terms for defenses, and tactical defenses are even more useful, I find, which came, I believe, from Davenlu. But you can modernize the language, and then if you want to go back and read about projective identification and all that, you can do that. I don't know what projective identification really is. Is it something flies out of your head and lands in the patient? How does it work? And I don't know what the neuroscience, I couldn't find yet what it is. How does it work? So some of those concepts, they're useful, but they're hard to explain. And people have other theories about it. But the idea of projection is an interesting idea and it's very useful in therapy, but how it actually works, no clue, I don't think. Some people think it's more, well, the mirror neurons, I think mirror neurons have been oversold. They work in monkeys watching other monkeys. I'm not sure how much the research is valid when you come to higher levels of emotion and so forth. But we do pick up other people's emotions. So I think that's where a lot of this comes from. What we call countertransference and projection is basically we have some way of sensing other people's emotion, if you're so inclined. So that's a bit about language. I'll leave it open there for questions or disagreements. Or validation if you want, I'll take that too.
I'll just say, share a thought that I had while you were talking about how it might be off-putting to engage with the older texts, and I can certainly sympathize with that, even though I do find a lot of richness in them sometimes, but also I find a very difficult and perhaps unnecessary way to teach people how to do psychotherapy, to say first you have to go through all these texts and then we're going to start teaching you stuff.
Yes.
That's not the way I would have liked to be to be taught. But I just thought maybe us Israeli Jews here who had to deal with weird texts from a very young age in a kind of obscure language we had to grapple with, but these texts have been revered and treated as very, very important. I think it made us more inclined to engage with these texts because I think the common thing here is we do treat the canonical texts of psychoanalysis as something fundamentally important to our training as psychotherapists here, and it's still quite a big tradition. So I was just thinking about how our Bible studies at school may have kind of trained us to do that. I don't know if people have other thoughts.
I had some thoughts. I'd like to share, continuing to what you said and what Alan, you talked about earlier about the basic things we need to know in order to learn therapy and psychodynamic therapy. I know that right now at the point where I also give supervision and sometimes to new interns, I always ask myself, what's the important things I'm going to address with someone that with
Yes.
rather new, and then I recall and I think of myself that.
So I can't hear you. Can you come a bit closer to the mic?
Yeah, sure. And then I'm thinking about myself at this point in my professional career where I was I was learning from basic, mostly psychodynamic, psychoanalytic based, and then I got to the experiential dynamic psychotherapy and learned then and saw and appreciated the attachment theory and affective neuroscience and those. But then I recall that as a therapist right now, I'm sitting on the shoulders of also of the psychoanalytic ideas, and I can't erase that, even if I'm not doing it like a lot of psychoanalysts or psychodynamic, and then saying, okay, I'm not sure if teaching someone and saying maybe they don't need all those psychoanalytic ideas. I don't know if they'll be better therapists, because I also use it. I still think in those terms, and and the idea of the multiple functionality of defenses. We can be also in order to avoid feelings, but can also be for for self sabotage or the need to suffer, which is also and also the idea of like projection identification, which are really elaborated in psychoanalytic literature. So I'm not really, I always ask my question, how much it's really needed, or how much is appreciated?
I mean, I think a lot of those ideas are incorporated into the short-term models, but without the theoretical background from the 20th, 19th century, But I think they're in everyday language. People are always talking about similar concepts just in day-to-day social life. I'm projecting, or I'm I'm very defended to, so many of those ideas, but to understand their origins, you would have to go back and see how they were discovered. There's also the viewpoint that the theory is for the therapist, not for the patient. Right. The theory helps the therapist decide what to do, but it's not necessarily, that use. Regardless of the theory, the psychotherapy research is much the same. I don't know about psychoanalysis because it has some unique features, like it goes on for a long time, many years, many cases. But yeah, I mean, you can, if you want to add that, I think it makes sense, certainly if you're teaching students, to start with what I'm talking about is the basic methods and processes. And then as you read, you might say, well, I want to go back and learn, what is a defense mechanism? We actually don't know what a defense mechanism is. I mean, we know what it is, we can see it and we can identify it, but what is it? Where's it coming from? I think it's when one part of the brain is threatened, it suppresses another part of the brain. So there's some kind of neuroscientific basis for a defense mechanism. There has to be, because that's how we work. But even without knowing that, we can still use the concepts. And as I say, some of the concepts are very poetic. I mean, I love Winnicott's language, he's almost like a poetic. His phraseology is so user-friendly and so relevant, to your own experience and what you see. So yeah, I'm not saying that the ancients be cast out, but just that you're not obliged to go in deeply, I don't believe anyway, to practice the short-term models.
May I add another issue or a question?
Yeah, that's
When you talked before about the differences between the approaches for experiential and dynamic therapy, I know that we are talking also about the therapist stance and how the therapist is dealing with defenses or emotions and anxiety. And what I thought while you were talking it was interesting also to look at it from the side of the patient's experience and what experiences is facilitated in those different three models. For instance, I said Davanou's ISTDP, while he's really relentless with the work in the defenses, and he's really sometimes in the work it can get to like major unlockings by doing that. Although it seems to be really tough and hard work. I think that this approach can facilitate for the patient a strong experience of the discovery. Like there is a breakthrough, and then suddenly he discovers the link, and it's like a big surprise for him. And I might, I'm wondering what is the outcome of this experience of the big surprise and big emotional discovery in cementing the therapeutic change, as opposed to like the experience that EDP has in making links and emotional links.
So I would say that AEDP and ISTDP are both trying to get to the same place, but with different terms. So as I say, Davanou's unlocking the unconscious. Diana Fasha talks about getting to core state. So, and she describes that as a state of insight, a state of calmness, a state of understanding, a state of emotion release. So I think you can get to analogous states. Now, do the methods work? Does one work better than the other? And I think not everybody likes a particular style. I mean, have worked with people and seen them here, colleagues who use ISTDP. My feeling about ISTDP is that it's a very specific model. It doesn't allow as much latitude. From what I can see, you follow the process and you watch the signals, the anxiety signals, and you go through stages of when you're ready to challenge and confront. I think it's a tough model. Does it have superior outcomes? I don't know. It may be in the more rigid, characterologically defended patients, it may be superior to AEDP, but I don't really have research in that. And it also depends on the personality of the therapist. We're attracted to one or other. So a lot of what we like to do has to do with as my first supervisor said, it has to do with your upbringing, that will determine whether you're a good therapist, your upbringing. So, but that's a joke. But basically, we have our own things that we're drawn to. When I first saw Davanouth, the only time I saw him was in 1976, I think. The whole conference, just were blown away. They said they'd never seen anything like this, and it seemed people reacted very strongly. But anyway, if it doesn't have to be as confrontational, and ISTD people would say it's not really confrontational, but it's pushing and pressing, and when they get to the breakthrough, I think there's a breakthrough in both forms of therapy. You can get to a breakthrough by, as Diana Fasha prefers, melting or getting past defenses. And You can use different bits if you want, unless you're involved in a research project. You can use, I will use some cognitive therapy, you know, about to help people who are depressed. You can draw in from other theories. Yeah, I mean, the outcome research, there's a view about psychotherapy outcome. Either they all work or none of them work. It's very hard to, because the methodology is so hard. And it's called the dodo bird effect. The dodo bird was a character in a famous English book, Alice in Wonderland. And there was some comment where everybody in the race got prizes. So everybody wins and they all have prizes, meaning that all the psychotherapy studied have similar outcomes if done well. And that's the common elements that people talk about in all therapies. The common element is the nature of the relationship and the empathy and all of those things. And the common element may be more important than the theory. The theory helps the therapist, but it's the common element that helps the patient maybe more. Okay. Anything else? I will show a little video if I can, if this works. So let me. Okay.
Psychologists have discovered that procrastination isn't caused by laziness or lack of motivation, but instead.
Okay, now I'm going to share my screen.
Hello.
Hold on.
My name is Dr. Alan Eppel, and I've been asked to meet with you today to help you with the problems that you have brought to us. My first question, though, is how do you feel about coming here to see me today?
Okay, can you hear that?
Yes.
So,
Can you increase the volume?
let me just go back. Should be.
Yeah, it might be that you need to click that share sound box.
Yeah, I'm trying to find that. Oh, there, they've moved it to another part of the interface. Okay. Yeah.
I guess in a way I was looking forward to it because
Is that better?
I've been dealing
Okay, so I'll go right back.
with stuff on my own.
So this is me.
Alan Eppel, and I've been asked to meet with you today to help you with the problems that you have brought to us. My first question, though, is how do you feel about coming here to see me today?
I guess in a way I was looking forward to it because I've been dealing with this stuff on my own for a while and trying my best, but not really getting anywhere, I guess. So I was looking forward to it for sure, but I'm also obviously a little bit nervous because this is new for me.
And what sort of things are you nervous about?
I guess it's hard to say. I guess just even being face to face, as much as we can be right now, being face to face, you know, with someone and just saying things out loud is not something I've done in a long time, and I don't really know. So I don't know how you're going to react to some of the things that I say.
So you're concerned that some things you might say will affect me in some way, or I might respond in a way that's difficult for you.
I guess, yeah.
So any comments about this beginning? Now, this person, as I mentioned in the video, she called Samantha. She does talk about her life, but it's not her real life. It's fictional. And she may be drawing on some emotions from her own life. Method acting, I suppose, if you want. But you see, I'm going very fast with how do you feel about coming here to see with me today, and how do you feel that I might be reacting to you? So I don't know if other people have feel that's not correct, or could be harmful, or may bring things in the wrong direction.
I would have a question, but maybe you want to relate to that later, and that is where it has to do with my experience as well. If a patient comes to you and you already know that he has a very specific problem, I see quite a lot of people with obsessive compulsive disorder. So they are referred to me because they think, rightfully or not, that I know something about obsessive compulsive disorder. I have difficulties with the whole diagnostic system, but I don't want to go into that. But you would do that in any case, and never mind if you knew that there was a specific problem, if you already knew that they came to solve a specific problem, or even if you didn't know the problem, in both cases, you would start with the emphasis on the relational aspect?
Yes. And I will read as much as I can about the patient beforehand. I'll look through the records on file, electronic records, but I will tell them that at some point. I will say I have read, the information online that we have on the records. For two reasons. One is if something that contradicts what is written comes up, then you're kind of checkmated. You can't use that. If you did, it looked like you tricked them. They will feel they've tricked them because you read something about them that they haven't revealed yet. So I this is with all patients, psychotherapy or not. I've read the notes, and then later on I said, well, what you're telling me now, what I read in the notes. So that's a slightly different topic, but it pertains to it. The other reason I do that is because, I don't know if it's the same for you, going to doctors or even cancer specialists and patients saying, well, the doctor hadn't even read my operation report, or they didn't check the x-ray results. There's nothing more invalidating, that you couldn't be bothered reading my chart, before the interview. So that's another reason I do that. But I was still open with this. Now, obviously, if the patient is flummoxed or too anxious or they retreat, I may have to modify it. But whatever comes up, then you deepen it, you explore it. Say, well, I was anxious about coming here, so tell me what makes you anxious coming here. And this is where you're judging, I suppose, what ISTB calls fragility. You may decide that the patient can't cope with some of those questions so early on. Now, ISTDP has a way of trying to judge fragility. I go just based on my clinical experience, based on the responses, based on facial expressions and responses and emotions that come up. The anxiety discharge channels, striatal muscle, smooth muscle, and cognitive disorganization. I think the ISTD people tell me they find that really, really useful. I haven't been trained and I don't use it, and I have never been able to find any scientific neuroscience correlations with that. Maybe I'm interested in any other views on that if people want, but I go mostly by body language and facial expression, what we call moment-to-moment tracking. Have you heard that word? moment-to-moment tracking is essential. You're watching their facial expression. Is there a teardrop there? Have they moved back in the chair? So that helps me to explore if they're tolerating it, or if they become upset or agitated, then obviously they're not able to tolerate it. And also some of the diagnoses, if they have a previous diagnosis of certain conditions which makes them, in quotes, more fragile or more prone to. Most of the patients, I think, that we tend to see for psychodynamic therapy tend to have been suppress their feelings. Those are the ones I think we select mostly. The ones who have too much feelings, they're too angry, or they're too emotional dysregulation, the borderline category. You can do psychodynamic with borderlines, but not if they're so emotionally dysregulated that you can't really contain the emotion. So dialectical behavior therapy, I do see people doing well with that. And those are the ones who have a lot of dysregulation and self-harm behaviors. It's a behavioral control. It doesn't take away the inner void, the subjective component, and the deep emotions that borderlines often refer to as a feeling of emptiness, of feeling invisible. That's much more difficult, and yeah. But yeah. Any other comments about the opening?
Yes, I'd like to ask, how far would you keep going with this? It seems to me that you're taking, the first question is tilting towards the transference. And I'm wondering if you would keep on going with this direction.
Depends on the response of the patient. I mean, if the patient is reacting negatively, I will go to some degree. Then we have to get back and, okay, you know, after a few minutes exploring it, I may say, now, then go to the problems. What are the problems that you're having? How much time I spend here, it's probably just a few minutes at the beginning. Depending, if nothing comes up that's worth exploring or that's possible to explore, then I may switch to the more history questions. On the other hand, if the whole story pops out, it can do in the first question, the whole life story. You know, I'm very anxious when I come to see doctors because my father beat me up. You know, the whole thing pours out. You don't necessarily go into all that detail yet, you know, particularly about abuse. You say, we don't have to go into the details today, but, you know, we can come back to it. But you get so much information quickly. And this is very different from, it's also, again, modern medicine is often checklist medicine. You go in and people ask you, go through a checklist. Do you have pain in your chest? Does it go down your arm? And do you have swelling in your ankles? There's no, or in a lot of cases, there's no human connection. So this is sort of also a counterbalance to that. So I will tell my psychiatry residents, they can do this with all patients, not just the ones coming for psychotherapy. You know, when somebody's coming for major depression, whatever it is, you can start off with this type of question, because it really can facilitate a very quick therapeutic relationship, because it's so different from what we see anyway here in everyday medical practice, which has, you know, we have family doctors who say, you only have 6 minutes, so you can tell me one complaint. I don't know if you've run into that. To me, that's not medicine. You know, if you have a pain in your chest and they say, well, it goes down my arm, I say, well, we're only looking at your chest today. We're not worried about the arm today. You'll have to make another appointment. This is insane. But anyway, so the idea of trying to maintain a humanistic and relational, I guess the relational interventions are the most powerful in psychodynamic. So we talk about transference and countertransference. But these are relational interventions where you're exploring the relationship. What Diana Fascia calls we interventions, you know, we're going to work together. She will start off by saying, welcome. When I saw that, I fell off my chair because in my psychiatry training, I never saw anybody say welcome because the relationship was very often conflictual. So, but yeah, the relational component, the relational interventions are the most important when you're deciding what to say next. Priority is the relational intervention, particularly if there's a rupture. So if there's, you know what I mean by rupture and repair? Because if you don't address a rupture and repair, you can't progress, if you can't repair it. Transference issues are a high priority. And then getting to affect, staying with affect is high priority. So the way I decide about which is the next intervention depends on intuition, but also what's the priority here, you know, is it affect or is it dealing with the rupture? So I look at it that way, and also guided by the patient's response. So here's something really important. Diana Fascia's definition of what is the unit of intervention in psychodynamic psychotherapy. Would anybody like to shout out something? What is the unit of intervention? What is it that we do? No takers?
I think I want to say the patient's true self or unconscious. I don't know if that's what you mean by the question.
No, it's what is the thing that we do? What do we do in therapy? What is our...
When you say we, you mean
I mean
the therapist?
Yeah. What is it that the therapist, what do we do? What do we, how do we intervene in a conversation?
We create a safe base for the patient to be. Like the attachment figure who let the baby go around while the mother is there. We try to create for the patient atmosphere in the room in which he can be safe.
Right. So, yeah. And how do you do that?
By help him regulate his emotion while being with me.
Yeah. Yeah, that's another whole area, regulating the level of emotion. But, so it's something you say that is the intervention. So we think of the intervention as something that you say and the patient hears. However, Diana Fascia says the intervention is not what the therapist says. It's what the therapist says and how it is received. So when you say something and you want to know how it's received, particularly if you see a change of facial expression or something. So when I said that you seemed very angry, how did you feel when I said that? You seemed to react a little bit when I said that. What was your reaction to that? That is the most important thing I learned from ADP. which Diana Foster calls meta-processing. You can say things, you can make mistakes, but you can repair them if you check out how was it received. And also, when you do some positive things, you want to know, you can meta-process. You can say, when I mentioned that when I said that I thought you were very courageous in dealing with this issue, how did you react to that, me saying that? So that's meta-processing. You're exploring at not just the level of what you're doing, but you're looking down. You're at the meta level. You're sort of saying, how was it received? Or how did you think I reacted when you told me that your father had abused you? How did you think I reacted when you told me that? Because the patient may have reacted to my facial expression or something. So meta-processing, I would say, if you take away one thing, I would say meta-processing. No matter what you do, you can meta-process. I think what Yoram said about emotional dysregulation is very important as well. If people are so angry or anxious, you may have to spend some time settling down, whether you use CBT techniques, box breathing, whatever, if they're that distressed. And you may not be able to go into anxiety-provoking questions, because these questions, whatever our questions are, they provoke some anxiety. History taking is an accusation. You know, we say, how many drinks do you have a week? You're accusing me of being an alcoholic. But all our history questions are like that for patients, depending on the background. You know, you ask them a routine question and they say, what? You think I'm X, Y, and Z. So understanding how the questions or the interventions land is very important, and also giving the patient an opportunity to talk about how they affected you or how they imagined they affected you. So this is all relational, and I would say the evidence says that the relational interventions are the most therapeutic because they're correcting, it's a corrective emotional experience from all the negative stuff that happened. But it's happening here in real time. You can do it in your head. You can talk about outside relationships. Well, when your boyfriend does that, how do you feel? It's much more powerful, as you know, when you do it in the room. When I said that, how does that make you feel? That's the experiential, and you want them to experience the feelings in the room, as opposed to, we don't want people to talk about feelings, we want people to experience the feelings. That's what's therapeutic. The right feelings. Now, there are some feelings that we want to minimize, in this theory anyway, and that's shame and guilt. Shame and guilt, we try to attenuate. You can't really process them in this model, I don't think. Because shame and guilt are sort of, somebody said they're infinite, you know. You try to attenuate them by supportive interventions and normalization. And again, same with guilt. But it's very hard to change, certainly in my hands, to change those sort of things. I think there are other approaches to shame, totally different, that I'm not trained in. But in AEDP, shame and guilt are seen as maladaptive and pathogenic affects. So there are, you know, the triangle. So we have defenses on the left side. Anxiety, shame, and guilt are on the right-hand side, and core affect and impulses are on the bottom. And we always want to get to the bottom of the triangle, and that involves dealing with the defenses or regulating the anxiety to get to the bottom. And people only stay at the bottom for a few seconds and then they slide away. So you have to bring them back and keep getting to the core affect. But shame and guilt are very very difficult. In my experience, I don't know what other people feel. I'll play
Alan, can we maybe see a little bit more?
Yes, I was just going to do that.
Okay.
When I start talking, I keep going, so you have to stop me.
I don't want to, I don't, a lot has happened to me, and I guess I worry about, I'm sure you've seen a lot and done a lot. I'm sure you're really experienced, but I, worry that I might scare someone with some of the things that I would say.
So you're worried that you may frighten me in some way, or that I might judge you in some way.
Yeah.
Okay, so what I'm starting off with here is I'm really exploring your reaction, which is the kind of therapy that we'll be doing together, is looking not only at problems that you're talking about, but how it affects the way you feel about yourself and how it affects your perception of me. And this is really central to this type of psychotherapy, which, as I mentioned previously before the interview, is called short-term dynamic psychotherapy. It focuses on problems, but also on how the problems manifest.
There's some noise. I'm not sure.
There's some noise.
Ran, if you can mute yourself.
Sorry.
Okay, see if that works. Relationship with therapist. So I understand already then these fears of how you might be seen or perceived by me. So let's move on to what the actual problems are that bring you here.
Okay. I guess it's interesting that the therapy is about relationships, because I think that that's the thing that I'm struggling with most in my life. I think my relationships with my family have always been quite difficult, and I always thought that I was pretty good at navigating them, I guess, but now that I'm an adult and I feel like I should have some level of separation from that and some kind of sense of self and individuation from them, I guess, like I still feel like those relationships affect me, and they bring a lot to my emotional world that I'd like to keep out. And so I don't know, I don't quite know how to separate from that. And at the same time, I have my husband, who's lovely, and we've been together for about 12 years now and married for about 5 years. And he's wonderful in so many ways. And I also, I don't think he quite understands where I'm coming from sometimes. And it's hard to talk about. It's, you talk about it with a friend, and, then it's kind of, they see the relationship differently, and it's hard to find people to talk about it with that can still, see me in that relationship, I guess.
And it seems like it's difficult for you to talk about it now. And that's, of course, you just met me, and it's hard to trust somebody with these personal things. But I wonder if you could give me some examples of the difficulties that you have in your relationships with your family.
Well, we'll get together for a holiday like Christmas or something like that. And I have a pretty big family. I have, 2 younger brothers, and I have a sister, and I had another sibling who unfortunately died when I was young. I think which makes things even more complicated a little bit.
Yeah.
My dad is no longer alive, and he was kind of the parent that I guess had a closer relationship with. And my mom,
If you're taking anatomy and physiology for the first time, I can guarantee it's not like any course that you've ever taken, and that's why so many students struggle with it.
I told you there's a secret study tool.
I have paid my dues. I'm not supposed to have ads.
Anatomy Bootcamp that is created for students like you taking anatomy for the first time. Here at Anatomy Bootcamp, we have hundreds of high-yield review videos packed full of mnemonics and helpful.
I feel we all paid our dues, but
I see.
Test day ready. High-yield notes
Oh
organized
my
the most
God.
important concepts we want to spend hours digging through textbooks. And 24-hour TA support to answer all your questions. For a limited time offer, you can try it for free. Print this ad and create an account. Literally takes less than 10 seconds. We've taken all.
my mom needs to be in control of everything, typically. So, and if we don't do things her way, if we don't toe the line,
We don't see the video.
Yeah, you're not okay. That's. I mean, yeah. Have to go back to share. Okay, go back to the video. Okay. Okay.
you know, meet her needs, no matter how, big or small they are, then it kind of has this ripple effect through the whole family of causing really negative things to happen. I don't know if that sounds really vague, but.
So I just wanted to just ask you how these dynamics affect your mood or your anxiety. What's the impact of these things at the present time?
I think I feel really lonely, and I think that loneliness is like only compounded by the fact that obviously there's a pandemic right now, and it's a lonelier time. But I think I feel very alone because I'm often in a role where I'm really supporting my siblings. I'm doing the best to support my mom, who is also doing the best that she can, but I feel like I don't really have anyone to support me and my family, and it makes me feel.
So I guess we're running out of time, is that right?
Pretty sad.
So there's a lot of sadness there, a lot of pain.
Yes.
But you can go to my YouTube channel and watch that. I mean, it's not perfect. It's for demonstration. It's compressed into 20 minutes. First interview is usually at least an hour, maybe longer, depending on your practice. But any last comments or questions?
I was going to ask earlier when you were talking about rupture and repair. But you sort of elaborated on it by explaining that you use these meta processing and checking how it is received, right? That's the big principle of checking how your intervention or how what you're saying is received, and that's lovely. I think it's a great takeaway for me. So I just want to say that, and also just a follow-up question: are there any other sort of big components or big things that you could highlight about how rupture and repair is viewed in AEDP?
Well, if you are always checking out and meta-processing, hopefully you can prevent a serious rupture, catch it sooner. If there is a serious rupture where the person's really angry, there is a whole literature, not specifically in ADP. It was I can't remember the guy's name right now, but there is a whole literature on rupture and repair if you want to search it. The founder, there was a group that published quite a bit on that, and I think they even have a little checklist to describe. They have different types of ruptures where people get angry and attack you, or they withdraw, drop out of treatment, and then you may call them and explore what happened. And sometimes it's impossible. You know, some people will react to something that you thought was quite minor, but they went berserk, you know, ballistic on you. But you try. Yeah, Saffron. Excellent, thanks. So those, he and a few others. And I think there's a few free videos as well by that group on YouTube.
Thank you.
I want to say hi. I want to say first, I really enjoyed this meeting, and I really appreciate your experience with different methods and putting them together in this way. And I also really liked the opening question, the surprising question. I think it's a really nice way to put yourself into the relationship and to convey your interest in intimacy and building something. I have this, I will try to make it short question. So you said something about the meta processes, and a lot of what I saw, I can also think of as investigating if there is projection. So when client says something about fear and you ask on the experience, or when you say something and then you ask how it was perceived, this can also be, I think, framed as undoing projection or trying to see if it's a projection. So I would love to hear your thoughts about this.
Yes, that's, you can be right. Yeah, I'd say that's correct. Either way, you want to know what they're feeling about you. Whether you think it's projection or whether it's based in reality, you have to decide. Yeah. So I would say that what you're saying is correct. Yeah.
But in a way, if you go there in the beginning, so it's going more to the projection field because there's no real relationship yet, I think. So it's like investigating.
Yes. Yeah, you could say that. But it also tells me that that is going to come up, you know, as a theme. Whatever you call it, but it'll be a theme. The other thing is, which we didn't have time to do, is a relational theme I usually put together. I don't know if you remember Laborsky, core conflictual relational theme. I have a much simpler way of doing it, which is based on, in attachment theory, we talk about internal working models. So we have a model of the self and a model of others. In object relations, it's called self and object representations. But in attachment theory, Bowlby calls it, we have an internal model of ourselves and of the other. And with this interaction very early on, very quickly, you can identify that theme. Just saw a new patient within a couple of interviews. The theme is she feels unworthy. That's her self-view, unworthy, stupid, and perceives others as rejecting and abandoning. So that's a core theme. And humans have actually a very limited set of themes. We're not that complicated when it comes to our reptilian, what Freud called repetition compulsion. We call recurring interpersonal themes. And some of that's also on briefly, I think, on the YouTube channel, I think. or you may, I don't know if you have access to universities that have ebooks or PDFs of books. They may have my book.
Yeah, actually, I bought your book to Ben Gurion University, which is a university in Be'er Sheva, in a city in Israel. So they for sure have your book.
They have it?
Yeah, also a hard copy I asked, so. Yeah.
Oh, yeah, it's much nicer in the hard copy. This is a conflict of interest. I shouldn't mention the book, but the royalties are not that significant. It's been translated into German, which I'm very pleased about.
Alan,
Yeah.
I would like to thank you very much for your generosity in coming to stay with us and to say some important points about short-term dynamic psychotherapy. You know, along our career as therapists, we're accumulating all kinds of concepts from here and then, first Freud and Anna Freud and Melanie Klein and more and more and more. And it's becoming a huge amount of concepts, and it's so nice. I remember a few years ago, I found this book, Escape from Babel, which is it is a very nice one. And your book is going on the same line with it, of trying to extract the core issues of psychotherapy. What is promoting healing? What is mobilizing the therapeutic moves? So thank you very much for open our eyes, my eyes, especially from the very beginning of the session, with the way you open it, and with the important issue you're addressing.
I should say one thing. Diana Fascia did not like my book because I said the three methods were the same, and she said, definitely they're not the same, and she has other concepts and other words which I found just jargony. But anyway, that was the longest email she ever sent to the listserv after I sent her my book, was how she disagreed with me. And I emailed back, and I said, because I do acknowledge her in the book a great deal, and I said, you know, I thought I wouldn't reply, but in the interest of scientific truth, I have to reply to your email. So I don't think she lists this on the ADP website. If you saw, because I've said things that are not acceptable. But each of these groups have their own business, you know, and they want to make sure in the United States, people go after these different methods, and they want to know which is the best one and which has, and so on. So she's done very well with promoting, and I learned so much. I learned so much that I only went back in to learn that quite old in my life, and I stopped wearing a tie. That was because I was able to drop the defense of wearing a tie. Coming from the British Isles, or wearing a tie was, you did that, you know. But now I can go, I know it's not quite casual, but I gained something.
But when you bring it up, I just put it up this week with, I think with my wife, we were talking about it. Maybe you can tell me something. What is the functional role of the tie? Or is it just...
I don't know historically what the function of, you know, it keeps you warm, I think, but I regard it as protecting your genitals, symbolically.
Alan, before we leave, can you maybe send to Ehud your email?
Yes, Ehud has my email, and you can send it to your group if you want.
Okay. I will put it on WhatsApp.
Okay. Well, thanks for having me, and it was a privilege to meet with